Hi friends, good morning to all of you. I am Dr. Anshul Bansal joining you on this Unacademy platform. In today's YouTube live session, we'll discuss very high yield MCQs, especially for the INICET and FMG examinations which are coming. The INICET is in the November and FMG is in December. So students participating for these examinations should buckle up and they should focus on their studies. Last INICET के लिए तो less than 1 month is left, so just give your best, do your studies very sincerely and focus on the MCQs and the question practice and the grand test. It is the best way to revise. Okay, so we'll study some high yield MCQs for the INICET and FMG today. Currently I'm working as an orthopedic house surgeon in SMS Hospital Jaipur, and I have cracked the NEET PG examination last year, that is in 2020 only. Okay, so let's start today's session, and before starting today's session I will just briefly guide you about various subscription plans that are available on the Unacademy for NEET PG. The first one is your Plus subscription. The Plus subscribers will get access to all the live as well as recorded classes. They can access the entire QBank and they can compete in live tests and quizzes, all of which is found by the topmost faculty for the NEET PG in India. And also we'll allow the subscribers to study on to log into multiple devices with the same account, so that they can study on any device of their choice at any time. And also for the subscribers who will be subscribing for 12 months or more, we will be shortly providing them with a printed notes. While subscribing, you can use my code, that is AnshulB10, to get extra 10% off. The second one and the best one is your Iconic subscription, and it is best not only on the Unacademy platform but across any digital platform in India. And what makes this best is that apart from the things that I have discussed earlier, in extra में you will get the prep ladder and all of the prep ladder, including its entire QBank, the video lectures, the rapid revision courses, the grand tests, quizzes, etc. Everything you will get. And on Unacademy extra में you will get well structured live batch wise classes, and we have structured a course and formulated our batches in such a way so as to build your basic concept about any subject or topic first, then going into its in-depth. And also after every test that you will the Iconic subscribers will get an individual test assessment sheet, so that you can analyze yourself, you can analyze your preparation, and you can analyze yes, this topic or this subject needs more revision, या किस type के questions आते हैं, या what are the important things that are frequently asked in the concerned topic or the subjects. Okay, or what are the things that I am missing. So it is very important to plan and analyze your preparation to crack any competitive examination. An Iconic subscription will provide you everything, and you can subscribe for this package using this code of mine, that is AnshulB10, to get extra 10% off. Special classes are very special. I always emphasize on this special class, and I always ask you to attend this special class regularly, because they'll give you extra edge over your competitors, and also they'll give you live classroom like feel, where you can interact with your educators in the live class, you can participate in polls, you can clear your doubts there and there only. And you have to just download the mobile application of the Unacademy and log in using this code of mine, both of which are absolutely free. And also after every special class that you'll attend, you will be provided with the digital notes of that special class. Now we have also launched a new feature that is called as raise a hand feature, where you can just tap on a button and digitally raise a hand, so that the educator will come to know about your doubt and you can solve your doubts and query there and there only. Because in COVID times, everyone is preparing through the digital platforms only, and to make this platform more interactive, to increase the participation of the learners and to increase the two-way communication between the learners and the educators, we have launched this we have launched this new feature. And please do solve and subscribe for a QBank, because it is best and highly effective. 25,000 plus questions तो है ही, but also the quality of the questions is very good because it contains every type of question that is required to crack any type of examination. It will cover your entire theory. It includes the recall and the previous year's questions, the high yield MCQs, the questions based on clinical case scenarios, okay, the recent advances, instruments, images, X-rays, CT, MRI, everything is included in this QBank. So please do solve this QBank before going for any of the examinations, and you can subscribe for the QBank using this code of mine to get extra 10% off. Now in October, we are organizing two grand tests, both of which are absolutely free. The first one is for the FMG aspirants examination scheduled in December, and this test is on 17th October between 10 to 1 p.m. And the second one is for the INICET going students. Examination is in November, that is on November 14th. Okay, so this grand test is also on 17th October between 2 to 5 p.m. in the afternoon, and please do give the grand test. Both are absolutely free, and think it like this way, that 3 hours of giving the test and 3 hours of solving the paper, reading the explanation and analysis. In 6 hours you will be able to revise and cover the topmost important 200 topics for the INICT and 300 topics for the FMG. So it will be a very high yielding 6 hours and a very high yielding exercise for you. So please do participate and give the grand test. Now dedicated to different sets of students who are preparing for different examination, like some are preparing for 2023 PG examination, or some are preparing for 2022 examination. So we have launched dedicated batches to these courses from 13th of the October, and also from the 13th of the October we have started a very interesting and important clinical case discussions and instrument batch. Here जो भी चीज आप थ्योरी में पढ़ते हो, sometimes they are very difficult to understand theoretically and you also get bored, but when you see that thing in a patient and clinically, yes, जो चीज मैंने पढ़ी थी ये patient में actually it looks like this, so it will develop your interest towards your studies and your subject, and also it will help you to understand the concepts बहुत अच्छे से, revise and remember the things बहुत लंबे time तक. So it is very important to build up your concept. So you can subscribe for any of these courses, and while subscribing you can use my code, that is Anshul B10, to get extra 10% off. Now here are the subscription packages of our iconic as well as the plus subscription, and you can see that the cost per month decreases significantly if you increase the duration of your course. Okay, so economically bhi acha hai, and academically also it is better if you go for the longer duration of subscription plan, because from the word go you wish to have a single source of information for all your subjects and your preparation, so that you don't have to hop around to different platforms for different topics of the subject, because it will waste your time, the revision will be very difficult, and understanding the things will also get very difficult. So I would suggest you to go for the subscription packages with longer duration, and while subscribing for any of the package you can use this code to get extra 10% off. Okay, so let's start today's session about high yield MCQs of the INICT and the FMG, and after every question I'll read the question and then give you some time to answer the question. You can type your answer in the live chat box, then we'll discuss the questions and all the options regarding that question. So let's start today's session, and the first question is: the proximal fragment of scaphoid after fracture is predisposed for avascular necrosis because, and here are your 30 seconds for this question. Okay, so chances of avascular necrosis is highest in case of in proximal fracture fragment of scaphoid because of this D. The option will correct answer will be D, that is retrograde blood flow to the proximal segment. There is a precarious blood supply, that's why proximal segment is predisposed for the avascular necrosis. Okay, there are three parts of the scaphoid: proximal one third, the middle one third, and the distal one third. The proximal one third is called as the pole, distal one third is called as the tubercle, and middle one third, and to be more specific, the junction between the proximal one third and the middle one third is called as the waist. Okay, so the most common site for fracture is the waist of the scaphoid, and the most common site of avascular necrosis is the pole. Even in case of fracture of waist, the most common site of AVN will be your pole. Okay, and remember, scaphoid fractures are hard to diagnose because they are sometimes missed in case of x-rays. Important oblique view has to be done, and serial x-rays has to be done in case of scaphoid fracture. And for scaphoid fracture, you go for a special cast called as the scaphoid cast, also called as the glass holding cast. Okay, so the most common location for fracture is the waist, and the most common site for AVN is the proximal pole. And there is a disease called as the Precers disease. And what is Precers disease? Precers disease is the idiopathic avascular necrosis of the proximal pole of the scaphoid. So idiopathic, it is the Precers disease. So here you can see this is your distal third or the tubercle, and this is your pole, and pole pe union rate is the worst and the least. Okay, union rate सबसे कम होगी आपके किस पे, pole fracture पे. और this is radius. Okay, so radius के ऊपर it is the scaphoid, and this is AVN of the scaphoid. Okay, this is the AVN of the scaphoid. Okay, now next question is, all of the following statement about SACH feet are true except. Here are here are your 30 seconds. Okay, so first of all, what is SACH? SACH is the solid ankle cushioned heel. Okay, solid ankle cushioned heel. It is basically a prosthesis without any intra-articular attachment, and it is the first or the basic prosthesis for the foot that is used in any type of patient. So it is the first and the most basic foot prosthesis that is used, called as the SACH, or the solid ankle cushioned heel. Okay, so this is correct. Okay, sorry, this is not the answer, so this is correct. Wooden kneel absorbs the impact of the heel strike. No. Forms the base of lower limb prosthesis. Yes. May wear out with time. Yes. So the incorrect option amongst them is the wooden kneel absorbs the impact of the heel strike. No, wooden kneel is not having this function. This function is of the cushion pad. Okay, so the cushion heel or the cushion pad will absorb the impact of the heel strike and not the wooden heel. Okay, see, this is the basic structure. This is your SACH foot. Okay, and यहाँ पे the upper part of the lower limb will get attached, and from the inside you can see there will be the cushion pad here and here, and this is your wooden kneel inside. Okay, so it is the simplest type of non-articulated foot as we have discussed. Okay, and there is a rubber heel wedge that makes the ankle action. Okay, the knee So see, this part is your kneel. Okay, this part is your kneel. So kneel is rigid and it provides the stability, especially mid stance stability. And this feet has no moving parts. Okay, it represents a basic, durable, and inexpensive prosthetic foot option. Okay, and this type of foot may be used with patients' very first prosthesis after amputation, as we have discussed. Okay, so this is also called as the stent foot or the stored energy foot. Okay, and here you can see it is a different foot than SACH because it is heavier and expensive but better than SACH. Okay, this is your stent foot. Okay, here you can see, and this is your SACH foot with cushion heel for shock absorber and the wooden kneel for the stability. Okay, so in this image you can very easily appreciate that this is your wooden kneel, this is your cushion heel for the shock absorber, this is your bolt for the fixation, this is your belting, and upper there is your plastic covering. Okay, now next question is, drug induced osteomalacia is known to be associated with the use of. Here are your 30 seconds. Okay, so the answer for this question will be your steroids. Steroids cause the drug-induced osteomalacia. Okay, whereas heparin and phenytoin causes drug-induced osteoporosis. Okay, remember ये भी बहुत important है. तो steroid will cause osteomalacia and heparin and phenytoin का overuse will cause osteoporosis. Okay, so sorry, the answer is not steroid, it is, yes, it is heparin. Okay, yes, sorry, phenytoin will cause the drug induced osteoporosis. Phenytoin will cause the drug induced osteoporosis. Okay, so remember like this कि phenytoin का overuse will cause drug induced osteomalacia. Okay, even I got confused. Phenytoin will cause drug-induced osteomalacia, whereas overuse of steroids and the heparin will cause drug-induced osteoporosis. Okay, remember phenytoin जो होती है इसके phenytoin and valproate के complications and side effects are very important. So just open your pharma books, take out 10 to 15 minutes and revise them. Okay, so phenytoin will cause drug-induced osteomalacia, whereas steroids and heparin will cause osteoporosis. Okay, now next question is, a 20-year-old male involved in single vehicle rollover accident presents with inability to abduct the shoulder and flex the elbow. There are the associated wasting of the supraspinatus deltoid and the biceps muscle. Which of the following is the most likely diagnosis? Okay, here are your 30 seconds. Okay, so the answer for this question will be upper trunk injury. Okay, see, abduct the shoulder, yani as we have discussed in the last class also yesterday ki C4 and 5 are related to the shoulder, and usme bhi elevation is for the C4 and abduction is by the C5. So first nerve root involved is a C5, and the flexion of the elbow C6 and 7 are for the elbow, and it may be C6 is for the flexion. So C5 C6 is the nerve root affected, and it is for the upper trunk injury, and it is called as the Erb's paralysis. Okay, Erb's paralysis or the Erb-Duchenne palsy, the upper brachial plexus injury C5 C6 लेवल पे. ओके, एंड वहां पे कौन कौन सी नर्व्स अफेक्टेड होगी? इट विल बी द सुप्रास्कैपुलर नर्व विच सप्लाइज द सुप्रास्पाइनेटस, इंफ्रास्पाइनेटस एंड टीरियस मेजर. Nerve to the subclavius musculocutaneous nerves which supplies the biceps brachioradialis and the coracobrachialis, and axillary nerve which supplies the deltoid and the teres minor. Okay, so there will the patient will not be able to abduct the arm and flex the elbow, and this is seen in upper trunk injury, that is the Erb's paralysis or the Erb's Duchenne palsy. Okay, very important, just remember this. Now next question is, all of the following are included as yellow flag signs of low back ache except. Here are your 30 seconds. Okay, so remember, lower back pain में yellow signs, red flag signs, blue flag and red black flag. ये signs are very important, and these are important especially for your INICET examination, because in the past 3 years these signs have been asked twice. Okay, so focusing on especially on the INICET FMG में आने के chances are very less, but in INICET it is very important, you should learn them. So yellow flag signs of the low back ache, these are the not so serious flag signs, and they represent the chronicity of the disease, or the disease is very chronic. Okay, so what are the yellow flag signs? So इसमें if you see कि believe that back pain is severely disabling, it is a yellow back sign. Reliance on the passive treatment, social isolation is the yellow black sign. Reliance on passive treatment is the yellow flag sign. History of systemic steroid use, it is a red flag sign. So the answer for this question will be D, that is history of systemic steroids use. Okay, so remember this is very important. History of systemic steroid use is considered as the red flag sign. Okay, and red flag are as we have discussed, it is a serious spine or a systemic disease. Okay, so here are the red flag signs. Red flag signs, as we have discussed, indicates serious spinal pathology. It includes thoracic pain, fever or unexpected weight loss, bladder bowel dysfunction, history of carcinoma or any other systemic medical disease, neurological deficit, disturbed gait or the saddle anesthesia in the perineal region, and onset is less than 20 years or more than 55 years. All these are the red flag signs, and also systemic steroid use is also a red flag sign. Yellow flag signs, these are the psychosocial factors indicative of long-term chronicity and the disability, and it includes the negative attitude that back pain is harmful. Okay, a patient is in depression, and he or she has generally lost hope of दी करेक्शन ऑफ द लोअर बैक एक. उनको ऐसा लगता है कि यार मैं अब कभी ठीक नहीं हो पाऊंगा. ओके, सो द साइकोलॉजिकल फैक्टर्स एंड द सोशल फैक्टर्स आर the major effective things in the yellow flag signs. Fear avoidance behavior or reduced activity in fear of pain. Okay, and they will be unable, and they will not do the active exercises. You have to passively force them to do the exercises. Depression, low morale, social withdrawal, social and financial problems, and compensation issues, all these are the yellow flag signs. Okay, so we have discussed the red flag signs and the yellow flag signs. Now we'll discuss the blue flag signs, which are the occupational or the social and economic factors like family reinforcement, work status, health benefits and insurance, litigation, etc. And socio-occupational black signs जो होते हैं, they are the insurance, litigation, work satisfaction, conditions, characteristics and the social policy. So occupation भी अगर include हो जाता है, then it is the black sign. Okay, red and yellow are the most important. Blue and black में आपको यही ध्यान रखना है that blue is for the social and economical factors and the black is focusing towards the work environment or the occupational factors. Okay, now next question is, there is considerable morbidity and mortality due to bone diseases most frequently among women. The most common cause of bone disease in India is? Very easy question. Here are your 30 seconds for this question. Okay, so very easy. The answer for this question is nutritional deficiency. In India, the most common cause of bone disease, especially in women, is most common is osteoporosis, which is due to nutritional deficiency. Okay, which is due to nutritional deficiency. So, or the steroid induced osteoporosis is also common. The most common is nutritional deficiency, especially calcium and vitamin D. Okay, remember this, very easy straightforward question. ज़्यादा दिमाग नहीं लगाना कि ये osteoporosis में तो serum calcium is normal and etc. Most common cause is the nutritional deficiency. Okay, remember this. A 12-year-old with rapid increase in weight and height over the past 1 year presents with difficulty in sitting cross-legged and squatting. The knee would go into the axilla every time she flexes her hip and the knee. The most likely diagnosis is? Here are your 30 seconds. Okay. Okay, so the entire history, especially the age group, that is early adolescence, the specific history of obesity. Okay, the specific history of obesity and a typical finding that sitting cross-legged squatting with difficulty and the knee would go into the axilla called as the knee axilla sign. All these are typical features of slipped capitofemoral epiphysis. So the answer will be B, that is slipped capitofemoral epiphysis. Okay, remember, it is very common thing asked in examinations, especially FMG examination में slipped capitofemoral epiphysis has been asked frequently. Okay, so obesity is the most commonly associated factor with this, and the sign have whenever you flex the knee and the hip, the knee will go till the axilla. This is called as the knee axilla sign. Okay, and it is also called as the excess deviation or the obligatory external rotation. Whereas in the Perthes disease or the Coxa vera, what are these? We'll discuss briefly about them. Okay, in दोनों में there will be abduction and internal rotation, not the external rotation. Okay, in Perthes disease and Coxa vera, there will be abduction and internal rotation. So this is a slipped upper femoral epiphysis or the slipped capitofemoral epiphysis, where you can see here you can see very easily, this is your femur head and this or the epiphysis. Here there is growth plate called as the physis, and due to any defect or abnormality in the growth plate, this head will slip down and will get slip down in the acetabulum, and it will lead to the disturbances in the growth called as the slipped capitofemoral epiphysis. So the treatment of choice for this is always surgery. You go for the closed reduction first, okay, then you fix it with the K-wire or special Moore spin. Remember this. But in many cases closed reduction is not acceptable because acha reduction is not achieved, so you go for the open reduction and internal fixation with the help of Moore spin or K-wire, etc. So this is your slipped capitofemoral epiphysis. Very important. Age group, obesity, knee axilla sign, okay, squatting and cross leg position mein you will have difficulty, okay, and a typical x-ray is given here. Treatment is your surgery, okay. Now what is coxa vara? See, neck shaft angle जो होता है femur का, femur's neck shaft angle is normally 120 to 140 degree. We are talking in case of children, okay, 120 to 140 degree. If the neck shaft angle is decreased, that is if it is less than 120 degree, it is called as coxa vara, and if it is more than 140 degree, then this is called as the coxa valga. So coxa vara mein the neck shaft angle will be decreased. So at birth the angle is more, that is around 140 to 160 degree, and it is around 120 degrees normally in the adult life, okay. So remember this. So 120 to 140 degree aim to दे रखा है, it is for the child age group, okay, not for the adults after the 30 and not for the newborn, okay. So remember कि 120 125 is the normal in case of adults, okay. So remember this is important, okay. So normal neck shaft angle जो होता है in adults, it is around 120 to 125 degrees, whereas in children or newborn it is around 150 degrees. It is normal, और उसके हिसाब से you can decide, you can tell the angles of the coxa vara, जिसमें the neck shaft angle will be decreased, and in coxa valga neck shaft angle will be increased. Now lag cave Perthes disease. Lag cave Perthes disease is a unique disease in which there is erosion and necrosis of femur head due to decrease in the blood supply. But remember, this is only temporary. After some time the blood supply will be normal, okay, and the necrosed or the erosed part will be healed, okay. So remember, this is temporary, yani this is a self limiting disease. Very important, remember this is a self limiting disease where the blood supply to the head of the femur is disrupted. Lag cave Perthes disease, okay. Now we'll come to the next question. The next question is, a patient with history of a recurrent posterior dislocation of the humerus is evaluated for a Hill-Sachs lesion. Which aspect of the head of the humerus is likely to show this lesion in the above patient? And here are your 30 seconds for this question, okay. Here are your 30 seconds for this question. Okay, so the answer for this question, Hill-Sachs is a depressed type of lesion in the posterior lateral surface of the humerus head. See, in case of recurrent dislocation of the shoulder, that too in the posterior or anterior, किसी में भी हो, most commonly in the posterior में Hill-Sachs and anteriorly में it will be the Banker's lesion. Okay, so very important, you need to remember these two types of lesion. तो सबसे पहले बैंकर्स लीजन जो होता है, बैंकर्स लीजन इज इन दी glenoid labrum and that too in the anterior inferior surface of the glenoid labrum, because there is dislocation के साथ stripping of the glenoid labrum, and sometimes if there is a bony piece avulsion with this glenoid labrum injury, then it is called as the bony Banker's lesion. Okay, so in this case of lesion with dislocation, the head will come in front of the scapular neck. Okay, so it is commoner and most commonly in the anterior dislocation. This is your Banker's lesion, whereas Hill-Sachs lesion, there is a depression or a notch in the posterior lateral quadrant. Okay, and this is in the posterior lateral quadrant. Here you can see very easily in the posterior lateral quadrant. This is your Hill-Sachs lesion, and in recurrent there is rounding off of the anterior glenoid rim. So rim is, if it is like this, so the head will get attached inside this very अच्छे से, but if it is rounded like this, so the head will not be attached very अच्छे से, so this will lead to recurrent dislocation. So this is called as the rounding off. Okay, you need to remember these three lesions, and Banker's and Hill-Sachs both have to be operated, and most commonly nowadays they are operated by the arthroscopic repairs. Okay, this is your Hill-Sachs region. Now reverse Hill-Sachs region, if the lesion is at the posterior lateral की जगह कहाँ पे हो जाता है, anterior medial. Okay, posterior lateral, posterior का reverse is your anterior and lateral का reverse is your medial. So posterior lateral का reverse, that is the anterior medial side में, it will be the reverse Hill-Sachs lesion. Okay, and remember, most common dislocation in the entire body is your shoulder dislocation, and shoulder may be most common is your anterior dislocation, and anterior may be most common is your subcoracoid type of dislocation. Okay, remember this. Now Bennett's fracture and Bennett's lesion, दो अलग अलग चीजें हैं but confusing. Bennett's fracture, as we know, is the fracture of the base of the first metacarpal or the thumb. This is your Bennett's fracture. And Bennett's lesion is the lesion in the shoulder where there is mineralization of the inferior glenohumeral ligament, and that to its posterior band. So shoulder में mineralization of the inferior glenohumeral ligament is called as the Bennett lesion. Okay, so read the lines very carefully. Okay, now we'll come to the next question. This question we have discussed yesterday night wale session mein only, but this is very important for both the INICET as well as the FMG, so that's why I have included this again. Okay, so a patient while lifting a heavy weight presents with sudden onset pain in the lower back radiating along the posterior lateral thigh and lateral leg to the big toe with numbness. Okay, the most likely diagnosis is, here are your 30 seconds. Okay, a history of heavy weight, जिसके बाद you have lower backache and the neurological signs like radiating pain, yani there is sciatica like pain and it is radiating till the big toe, and big toe का myotome is your L5. extension of the big toe. So L5, so L5 will be the answer. So L5 is in two options now, L4 L5 and L5 S1. So as I have told you yesterday also, if such is the case, then the answer will be L4 L5, because the L4 L5 disc prolapse में the L4 will be the exiting nerve root, and the nerve root will get exit before the compression, and L5 will be your traversing nerve root. So किसी भी डिस्क प्रोलैप्स में जो नीचे वाला nerve root होता है, it will be the affected one. Like in the L2 L3, L3 nerve root will be affected, whereas L2 will be normal. Okay, so remember this, that L5 big toe, इससे big toe आते ही you can diagnose that it is L5, and L5 में L4 L5, because L5 is नीचे, it is the traversing root. That's why the answer is L5, sorry, L4 L5. Okay, so L4 is your exiting nerve root, whereas L5 is your traversing nerve root, and in classical cases the traversing nerve root is affected. Okay, remember this. Here you can see this is your vertebral body, this is your spinal cord, this is your spinous process, and here you have the anterior longitudinal ligament, this is your posterior longitudinal ligament, and here you have the supraspinous ligament and the ligamentum flavum, etc. And this is your intervertebral disc, and here you can see this there is prolapse of this intervertebral disc, and it is impinging and compressing the nerve roots here. Okay, यहाँ से भी you can see that this is your S1, so it is your L5, this is your L4. Okay, so L4 L5 के level पे there is disc prolapse. This is the thing, and you need to remember certain myotomes. Okay, L1 L2 is for the hip. Okay, L3 L4 is for L3 is for the knee. L4 L5 is for the ankle में dorsiflexion, and L5 specifically for the great toe or the first metatarsophalangeal joint, and S1 is for the ankle में plantar flexion, and rest sacral ones are for the bladder and bowel incontinence. Okay, so remember this. Now next question is, which of the following is the least likely complication of fracture neck of femur? Here are your 30 seconds. Okay, so the answer for this question will be A, that is malunion, because remember we have studied that fracture neck of femur is such type of fracture which never unites, and fracture of intertrochanteric femur, that is IT femur, is the fracture which will always unite. So non-union, so IT femur में there will never be non-union as a complication, and in neck of femur malunion will never be a complication. There can be shortening, avascular necrosis is its typical feature, non-union is its typical feature. Answer will be your malunion. Okay, remember it is very important. So that's why fracture neck of femur में the treatment is always operative. Okay, remember, always operative, except one case, Garden classification type 1, that is the impacted fracture mein you can go for the conservative management by the traction, etc., because that is undisplaced and also incomplete fracture. Okay, so fracture neck of femur may treatment will always be operative. So if the patient is young, okay, if the patient is young adult, then you go for the corticocancellous screw or the DHS, and if the patient is elderly, then you go for the Hemi Arthroplasty, and that too the bipolar Hemi Arthroplasty, where you have movement in the two directions. Okay, so this is the blood supply. This is the blood supply of the femur head or the proximal femur, and here the three important things that, or the three important arteries that are concerned with the blood supply. First is your lateral circumflex femoral artery, second is your medial circumflex femoral artery, and third is your foveolar artery. Okay, third is your foveolar artery or artery to the ligamentum teres. Okay, so in case of fracture neck of the femur, the two major supplies, that is the lateral circumflex and the medial circumflex, are disrupted. Only foveolar is left, which is not enough, and hence the femur head will go into the avascular necrosis. Okay, so fracture of neck of the femur, there are two types, intracapsular and extracapsular. Intracapsular yani inside the capsule of the hip joint, so it is your neck of femur fracture proper, and extracapsular is your intertrochanteric or the IT femur fracture. Okay, so in दोनों में differentiation is very important. Fracture neck of femur never unites, it reunites readily, we have already seen it. Now in case of IT femur fracture, the signs and symptoms will be more. Both of the fractures are due to trivial trauma, especially in the elderly age group. Okay, remember the age group is the elderly due to trivial trauma. Signs and symptoms and deformity, signs and symptoms like pain, deformity. Okay, let me connect my charger. Here it is. So signs and symptoms as well as deformity, okay, pain, etc., all these, and the displacement, all these will be more in case of IT femur, okay, as compared to the neck of femur. What is this? This is fracture neck of femur of the left side. Okay, of the left side. Here you can see this is your fracture neck of the femur, this is your ilium, this is your pubic symphysis. Okay, this is your hip joint, head, neck, greater this is your greater trochanter. Okay, and here you will have GT like here, and here this is your acetabulum forming the hip joint. Okay, this is your ilium, this is your ischium, this is your pubis. Okay, and here you can see fracture of neck of femur. So classification of neck of femur fracture is very important, and there are three types of classification, and you need to remember all the three types of classification. The first one is based on the anatomical location of the fracture. Subcapital, okay, here you can see this is your subcapital, okay, most proximal most, then the mid of the neck is your transcervical, and most distal one is your basicervical. Okay, subcapital, transcervical, basicervical, and AVN के chances सबसे ज़्यादा is in your subcapital type of fracture neck of femur. Okay, the more proximal the fracture, the worse is the prognosis. So now second type is your Powell's classification, which is based on the Powell's angle. What is Powell's angle? A horizontal line at the tip of the head with the angle forming with the fracture line. This is your Powell's angle. Okay, 1, 2 and 3 में divide हो जाता है. So जैसे जैसे the fracture will go in towards the distal side, the Powell's angle will get increased. Okay, so the type 1, the angle will be less than 30 degrees, type 2 30 to 50 degrees, and if it is more than 50 degrees, then this is your type 3 of the Powell's angle classification. Okay, remember this. And Powell angle के हिसाब से, the more the angle, the worse is the prognosis. Now very important is your Gardner's classification, which is based on the degree of displacement, and यहाँ पे जो important word है that is your rotational displacement. Okay, that is your rotational displacement, and it is classified into four stages. Okay, this is the four stages of the Garden classification. The first stage is your undisplaced stage and incomplete stage. Okay, incomplete and undisplaced, and it is also called as your impacted fracture or the abducted fracture. Stage 2, where fracture will be complete but undisplaced. In stage 3, fracture will be complete and displaced, but displacement is such that the head and the rest of the femur are still in contact with each other. Okay, so the head will be in the and the limb will be in the external rotation. Okay, it will be in the external rotation, whereas in type 4 the connection between them is lost, so there is complete fracture and complete displacement, and complete displacement हो जाता है, so the head will again pop up in the cavity of the acetabulum. Okay, so stage 1 is called as the impacted and the abducted fracture, and it can be the only type of fracture of neck of femur that can be managed conservatively. Okay, and in stage 3 the distal fragment will rotate externally and head ka rotation will be in the internal rotation. Here you can see this is your type 1, 2, 3 and 4, whereas in fourth type what will happen, it is fully displaced, so the distal fragment will rotate more in the external rotation and lose the contact with the head, and the head will spring back to its original position. Okay, so this is your Gardens classification. And radiological features mein, first of all you need to have a x-ray of bilateral hip joint pelvis, because you need to compare both the pelvises. And what are the radiological features? There will be a break in the medial cortex, external rotation evident होगा, जिसकी वजह से lesser trochanter will be prominent. Okay, there will be overriding of the greater trochanter, break in the trabecular stream and break in the Shenton's line. Okay, now what is Shenton's line? Where is the x-ray here? Yes, this from the medial side of the proximal segment, okay, till the superior pubic rami के inferior border तक you have the Shenton's line. But in case of neck of femur fracture, this Shenton's line is broken. Okay, so there is break in the Shenton's line, remember this. Okay, so there will be shortening both in the horizontal as well as the vertical axis. Young adults may you will go for the CC screw fixation, that is the corticocancellous screw fixation, and the dynamic hip screw or the DHS. Okay, and a special type of osteotomy which was used earlier, not used nowadays, but you just need to remember the name. This, that is your McMurray's osteotomy, used in fracture neck of femur. Okay, this is your McMurray's osteotomy. Now this is your Hemi Arthroplasty. Here you can see why this is not a complete arthroplasty, because only one end of the articular surface, that is your femur head along with the neck and the stem, is changed. The acetabulum is not replaced by the prosthesis. So this is hemiarthroplasty, only one side is changed. Okay, it is of two types, unipolar and bipolar. So unipolar mein only one movement hoga, but bipolar mein there will be movement in the two planes. So this is your bipolar hemiarthroplasty, which is the treatment of choice in case of fracture neck of femur in the elderly. And एक और procedure होता है specifically for the neck of femur, useful earlier but nowadays less used. Just remember the name, that is Mayer's procedure. So Mayer's procedure and McMurray osteotomy is for the fracture neck of the femur. Now we'll come to the next question. The next question is, median nerve lesion at the wrist cause all of the following except. Okay, here are your 30 seconds for this question. Okay, so median nerve में thenar atrophy or thenar muscles wasting, yes, it will be there. Weakness of the adductor pollicis, no. Weakness of first and second lumbricals, yes. Flexor pollicis brevis, yes. So weakness of adductor pollicis will not be seen in case of median nerve palsy. It is seen in case of ulnar nerve palsy. Okay, it is seen in case of ulnar nerve palsy. Okay, so the adductor pollicis is supplied by the deep branch of the ulnar nerve. Okay, deep branch of the ulnar nerve. So median nerve is important. The nerve root is C6, C7, C8 and T1, and it arises from the median, so medial and lateral cords of the brachial plexus. In the forearm, it is between the two heads of the pronator teres, because the main काम जो होता है, it is in the flexor compartment. Okay, so it supplies the entire muscles of the flexor compartment or the anterior compartment except two muscles. Okay, first is your flexor carpi radialis ulnaris, and second is your medial head or medial half of flexor digitorum profundus. Both of these are supplied by the ulnar nerve. Rest all flexor muscles or tendons are supplied by the median nerve. Okay, so in the forearm, it is between the two heads of the pronator teres. Okay, and in the mid forearm, it is between the flexor digitorum superficialis and profundus, and in the wrist it becomes superficial just beneath the flexor retinaculum. Okay, and यहाँ पे compression की वजह से there is a syndrome called as the carpal tunnel syndrome. Okay, so thenar eminence muscles ko the supply is by the median nerve, and it includes three muscles: the abductor pollicis brevis, abductor opponens pollicis, and the flexor pollicis brevis. Okay, and the flexor pollicis brevis. Okay, so इसको median nerve की supply in the hand को याद रखने के लिए there is one mnemonic which is remembered as LOAF, LOAF. Okay, LOAF means lumbricals, the first and the second lumbricals. O for opponens pollicis, A for remember abductor. Okay, abductor, and F for flexor pollicis brevis. Okay, and it is abductor pollicis brevis. Okay, so loaf से याद रखना median nerve. Okay, so and median nerve then finally divides to 4 to 5 digital branches supplying the area of the skin. Okay, so skin में if you see the anterior part of your hand, the medial medial 1.5 fingers, that is your ring finger ka half, and your entire little finger is supplied in the anterior as well as posterior by the ulnar nerve, whereas 3.5 fingers mein anterior by the median nerve and posterior 3.5 fingers by the radial nerve. But there is a catch, एक छोटी सी चीज you need to remember, that this lateral 3.5 fingers जो होती है, that is the thumb, index and the middle fingers, इसका भी posterior nail bed तक का जो area होता है, till the nail beds, it is in the posterior part of the nail beds also, it is supplied by the median nerve. Okay, remember this thing. So except flexor carpi ulnaris and medial half of the flexor digitorum tendon, all the flexor muscles of the forearm which have the functions of the pronation, flexion and opponens pollicis, the opposition of the thumb, like this. So these are all the functions of the median nerve. Skin innervation, anterior medial in the forearm and anterior medial in the forearm, and in the hand we have discussed. Carpal tunnel syndrome we have already discussed. Okay, the supplying जो supply करती है median nerve muscles, we have already discussed. Now test, there are two types of palsies. Okay, high median nerve palsy, yani it is above the elbow, and low median nerve palsy if it is below the elbow. Remember this. Okay, so high median nerve palsy में क्या होगा? हाई मीडियन नर्व पाल्सी में the entire median nerve की muscles will be paralyzed, whereas in low median nerve palsy there will be sparing of the forearm muscles, but the muscles of the hand will be paralyzed. Okay, because the injury in lower median nerve is below the elbow, and that too in the distal forearm wale part mein. Okay, remember, so only hand muscles paralysis in case of low median nerve palsy. Okay, so high median and the low median nerve palsy we have already discussed. Now we'll come to the specific test for the specific muscles that is supplied by the median nerve, which help you to diagnose the injury key, yes, which nerve is injured. Okay, it is important. Now for the flexor pollicis longus. Okay, flexor pollicis longus का जो काम होता है, it is flexion of the digits. Okay, and that to the terminal phalanx of the thumb against the resistance. Okay, this is your flexor pollicis longus. Okay, whereas flexor digitorum superficialis and the flexor digitorum profundus ka lateral half, they will do the flexion of the thumb, index and the middle fingers. Okay, so in case of median nerve palsy, if you hold to clasp the hand, normally I can do like this, but in case of median nerve palsy I will not be able to do the flexion. This is called as the pointing index or the Ochsner's clasp index. Okay, pointing index or the Ochsner's clasp index. Now other fingers are not pointing. Why? Because they are supplied, the medial half of the flexor digitorum profundus is supplied by the ulnar nerve, as we have discussed. Now flexor carpi radialis is supplied by the median nerve. So if you will test this nerve, and if you ask the patient to flex at the wrist, okay, then the wrist will deviate towards the ulnar side on palmar flexion. The wrist will deviate towards the ulnar side like this. Okay, now thenar muscles, 3 thenar muscles होते हैं, उसमें से you can test only 2 muscles. You cannot test the flexor pollicis brevis. Okay, now abductor pollicis brevis, see, this is your adduction, abduction, adduction, abduction. So इसके लिए you put a pen here like this. Okay, I'll show you like this. You put a pen here like this, and the thumb can touch the pen. This is your pen test, which was asked in this year's NEET PG, and this is your median nerve abductor pollicis brevis, the pen test. Okay, in yesterday also there was this thing, and I have told that it is for the, I remember, like, I have told you wrong that it was ulnar nerve. So if I have told you that it was ulnar nerve, then correct it, it was the median nerve. So pen test, abductor pollicis brevis, and the opponents is to oppose the thumbs with the other fingers. This is your opponent's pollicis. So swinging movement like this will be absent in case of median nerve injury. Okay, so this is your flexor pollicis longus ka the terminal phalanx flexion of the thumb. Terminal phalanx flexion of the thumb is the function of the flexor pollicis longus, whereas abductor pollicis brevis is tested by the pen test, and Ochsner's clasping index will test the flexor digitorum superficialis and lateral half of the flexor digitorum profundus like this. Okay, this is flexor carpi radialis ka assessment. Wrist will deviate on the lateral side, so sorry, the ulnar side, that is the medial side, and this is your abductor pollicis brevis ke liye pen test, which was seen which was given in NEET PG 21 this year. A simple straightforward one-liner question, image based question was there. Okay, so please do remember. And due to the thenar atrophy, in case of median nerve palsy, you will have the ape thumb. Okay, and also flexion cannot be there in case of median nerve palsy, so you will have like this, the benediction hand or the hand of benediction. Okay, this is also a typical feature of the median nerve palsy. Okay, now we'll come to the next question. Next question is, The characteristic triad of Klippel Field syndrome includes all of the following except. So here are your 30 seconds. Okay, Klippel Field syndrome is an autosomal disease. Okay, and it have the typical triad of posterior lower hairline. Okay, posterior lower hairline, limited neck movements, yes. Short neck or webbed neck, yes. Elevated scapula, no. Okay, so the answer for this question will be elevated scapula, because the characteristic triad of Klippel Field syndrome does not include elevated scapula. Okay, so it is due to congenital fusion in the cervical vertebrae. Very important. Klippel Field syndrome is due to congenital fusion of the cervical vertebrae, जिसकी वजह से length neck की length will become, so, and also the movements in the neck will be less. Okay, and there is failure of abnormal segmentation of the cervical vertebrae. Okay, and Fields triad may you have the lower posterior hairline, as you can see here, short neck and limitation of the head and neck movement. Okay, so this is your Klippel Field triad. C2 C3 fusion is autosomal dominant, C5 C6 is autosomal recessive. Itna deep mein you don't need to remember. Okay, here you can see the fusion of cervical vertebra. Okay, typically seen in case of the Klippel Field syndrome. Okay, elevated scapula is not the part of the classical triad. Now next, very easy question but very important, is brown tumor is seen in. Here are your 30 seconds. Okay, so the answer for this question very easy, is your hyperparathyroidism. Hyperparathyroidism का typical feature होता है, it is your brown tumor. Okay, see, parathyroid hormone, the PTH function is to increase the serum calcium and decrease the serum phosphate, because it increases the bone resorption. Okay, and it decreases the reabsorption from the renal tubules of the phosphate, or it increases the excretion of the phosphate. So that's why serum calcium will be increased, whereas serum phosphate will be decreased in case of hyperparathyroidism. Okay, so Brown's tumor primary hyperparathyroidism की वजह से होता है, which is also called as the von Recklinghausen's disease. Okay, von Reckling disease, and the most common site is your mandible followed by the maxilla. Okay, so it is very important, the most common site of brown tumor is your mandible, and it is seen in case of primary hyperparathyroidism called as the von Recklinghausen's disease. Okay, इसके अलावा जो other radiological features होते हैं we'll see अभी. Okay, so focal bony lesions होते हैं. Okay, due to they are the lytic lesions due to increased osteoclastic activity with fibroblastic proliferation in case of hyperparathyroidism. Okay, most commonly in the mandible, ribs, clavicles, pelvic girdle, etc. Okay, so hyperparathyroidism में क्या होगा, more PTH will lead to more activation of the adenyl cyclase enzyme, which will lead to more cyclic AMP formation, and which in turn will increase the synthesis of lysosomal enzymes. Okay, lysosomal enzymes का जो synthesis होता है, it will get increased, and there will be breakdown of the organic matrix of the bone and release of the calcium. It is more common in the women between 30 to 50 years of the age. Very important, this age group पे question आता है. Okay, and most common initial or the first symptom is your bone pains. Okay, bone pains, and there can be generalized weakness, pallor or hypotonia, and pathological fractures, because bone resorption is very great, so there are lytic lesions and the bone becomes weak, so there are chances of pathological fractures. And most common pathological fractures is your spine fracture, that too in the thoracolumbar or the dorsolumbar spine, followed by the neck of fracture, neck of femur fracture. Okay, so Brown's tumor is basically a collection of the osteoclasts. It is basically connection of the osteoclast and bone pain के साथ the most common presenting complaint is your loss of hunger, that is anorexia, nausea and vomiting, and abdominal cramps. This is the typical common presenting complaints with bone pain. Okay, anorexia is loss of appetite. Okay, here you can see a typical salt pepper appearance of the skull in case of hyperparathyroidism. Okay, in case of hyperparathyroidism. Okay, here you can see there is osteopenia. Okay, there is subperiosteal resorption of the bone. Okay, bone resorption, osteopenia, lytic lesion in case of hyperparathyroidism. This is the typical X-ray finding of the hyperparathyroidism. So there will be salt and pepper appearance in case of skull, and in teeth there will be loss of lamina dura. So now what is lamina dura? क्या होता है? A tooth socket is made up of thin bone. Okay, and it is seen as a white line surrounding the teeth, which is the cortical part of the tooth socket जिसमें teeth is fixed. Okay, this is called as the lamina dura, but there is resorption of this lamina dura. Okay, here you can see this is your teeth, and यहाँ पे the white line की जगह there is, this is your lamina dura, this white line is your lamina dura, but this lamina dura, this is your normal, not in hyperparathyroid, this is your normal image, but this white line will be resolved in case of hyperparathyroidism. And in spine you will have a typical feature called as the rugged jersey spine, where there will be resorption of the vertebral body. So vertebral body will be more radiolucent like this, and this typical vertebrae is called your rugged jersey spine, specifically seen in case of hyperparathyroidism. Okay, so subperiosteal resorption of the phalanges is diagnostic, like we have seen here. Okay, subperiosteal resorption. There will be central collapse of the vertebral body, and the discs will be biconvex. Brown's tumor we have discussed. Renal calculi के chances बहुत ज़्यादा हो जाते हैं because serum calcium is increased. Okay, now other investigations: serum calcium increase, phosphates low, and alkaline phosphatase will be high, and all these are normal in case of osteoporosis. Osteoporosis में all these three are normal. Remember this. Urinary excretion is low of calcium, whereas phosphate का high होता है, and you have to do the CT scan or USG of the parathyroids to detect the secreting sites की कोई ectopic parathyroid gland तो नहीं है. So treatment, सबसे पहले identify the cause and treat the cause. Orthopedic treatment में you go for the protection of the from the pathological fractures, giving support while walking, etc. And urological treatment is treatment of the kidney stones or the renal functions. Okay, so this is your brown tumor here. Okay, now we'll come to the next question. Next question is, a patient involved in a road traffic accident presents with quadriparesis, sphincter disturbances, sensory level up to the upper border of the sternum, and a respiratory rate of 35 per minute. The likely level of lesion is. Okay, here are your 30 seconds. Okay, so the answer for this question will be C4, C5. Okay, the answer for this question will be C4, C5. There is quadriparesis. Okay, okay, sphincter disturbances with up to upper border of the sternum, which is the level of the C4, C5, and respiratory rate is high. Yani there is problem in the supply of the diaphragm also, leading to the respiratory arrest. Okay, so C4, C5 is the answer. Now next question is, which of the following statements about menisci is not true? So here are your 30 seconds. Very important question. Okay, okay, now let's discuss. सबसे पहले medial menisci is more commonly injured with the lateral. Yes, it is correct. The medial menisci most commonly is injured with the medial collateral ligament, both of which are connected. So इन दोनों की injury generally साथ में होती है, and इसके साथ में अगर ACL की भी injury हो जाए तो it is called as the terrible triad of the knee, or also called as the O'Donoghue triad, especially seen in rugby players or football players etc. medial malleoli plus medial collateral ligament, ये दोनों तो attach होते हैं. इन दोनों की injury mostly they are together, and if there is injury to the ACL also, then it is called as the O'Donoghue triad. So medial menisci is more prone to injury. Yes, and why it is more prone to injury? Because it is more stiff and it is more tight, less flexed. That's why it is more injured. So medial menisci is more mobile than lateral. This is the wrong option. So the correct answer is B. Menisci predominantly made up of type 1 collagen. Correct. Lateral menisci covers more tibial articular surfaces than medial one. Correct. Okay, so the answer for this question, or the incorrect statement, is that medial menisci is more mobile. No, it is less mobile, it is more tense. Okay, so here you can see this is your lateral and the medial side पे bridging one are your lateral and medial collateral ligaments, and यहाँ पे ये गद्दे जैसी चीज is your menisci. Okay, menisci are gadda, ऐसे याद रखना, menisci are gadda or the cushions, and here in form of cruciate or cross you will have the anterior and the posterior cruciate ligaments. Okay, so menisci is a gadda. Okay, and it deepens the articular surfaces, like glenoid mein there is glenoid labrum. Okay, whereas in the acetabulum there is acetabulum labrum also. So वैसा ही काम यहाँ पे menisci करता है, that is they deepen the articular surfaces, and गद्दे हैं so they will act as the shock absorbers. Okay, they are C-shaped, like you can see. Okay, they are the C-shaped menisci. Okay, now most common menisci tear is your bucket handle type of tear. Okay, most common is your bucket handle tear. Now mechanism, menisci are related to the rotational stability. ये याद रखना, rotational stability of the knee joint is the function of the menisci, and whenever there is first episode of menisci injury, you will have a click sound or a jhatka type of sound. Okay, so twisting movement with a flexed knee hota hai, and here you will have a typical click sound or a jhatka, and your knee will be locked. Then either you yourself or with the help of assistant, you can easily unlock the knee, and with some pain you can walk. But if you do not consult the good doctor, and you don't go for the proper rest and the exercises and the therapy, then the injury will get more and more increase, and there will be more and more tears in the medial menisci, leading to a major injury like the bucket handle type of tear. And in that case, there will be frequent locking of the knee with rotational instability and chronic severe pain, and then the treatment of choice for you will be arthroscopic repair only. Okay, so the menisci may be torn with a minor twisting also. Medial menisci is the more often one that is being torn. Okay, and the menisci are the avascular structure. So if there is injury of a menisci, then it is very difficult to heal. Okay, and they are the articular parts. Okay, just they are at the cushions of the tibia, pads of the tibia, of the articular surfaces. Though inki injury can lead to very easily osteoarthritis. So commonest type is your bucket handle that we have already discussed. So the patient will have recurrent episodes of pain, locking of the knee, झटका or something flicking inside the joint. So there is locking. ये important feature होता है किसका, menisci injury का. So every successive episode of locking may be either spontaneously corrected or may need manipulation by the patient or the physician. Okay, so very easy, we have discussed all this. The knee will be locked, and इसमें the knee will be swollen. Okay, and range of motion will be decreased, and you have to check the rotational stability to rule out injury to the menisci. And for this you have two important steps, important tests, that is the McMurray's test and the Apley's grinding test. Okay, name, at least you should know ki yes, these are related to the McMurray's test, whereas anterior drawer test, Lachman test, these all are for the ACL. Okay, so a McMurray's test and Apley's test is for the medial menisci. So this is your McMurray's test. Abhi we have read McMurray's osteotomy. So McMurray's osteotomy is for the fracture of neck of femur, whereas McMurray's test is for the injury of the medial menisci. Okay, so remember this, don't get confused. So here, while stabilizing the ankle with one hand and knee with one hand in the flexion position, you will rotate the knee. Okay, then you will check the stability of the knee, and this is your Apley's test in posterior position or the prone position. You with leg flexed or the knee flexed, you will rotate the ankle like this to check the rotational stability. This is your Apley's grinding test. Okay, now we'll come to the next question. The next question is, which of the following statement about changes in articular cartilage with aging is not true? Read the questions very carefully. So here are your 30 seconds. So let's discuss the question. Total proteoglycan content is decreased in case of aging. Yes. Synthesis of proteoglycans decreased. Yes. Total water content of the cartilage is decreased. Enzymatic degradation of proteoglycans? No. There is no enzymatic degradation of the proteoglycans. So the incorrect option or the correct answer for this question will be your D. Very straightforward question. Okay, so articular cartilages are soft white tissues that cover the articular surfaces of the joints when they of the bones when they form the joint. Okay, and they'll give you a smooth support, frictionless support for the better movement and easier movement and the easier gliding movements. Okay, so now next question is, lift off test is done to assess the function of. Okay, here are your 30 seconds. Okay, so lift off test is done for the rotator cuff muscle का testing के लिए of the shoulder, and उसमें भी it is done for testing the subscapularis muscle. Okay, it is done for the testing of subscapularis muscle. So subscapularis test or the lift off test कैसे करते हैं इतना डिटेल में you don't need to go for your competitive examinations, but for your prof or university examination के practical के लिए you should read, and also you should read when you get time, especially in the MBBS, because you will learn that what are the functions of the muscles, and you will help to understand the muscles. Ratification will be less and you will be it will be helpful for better understanding. So in today's session we'll only discuss कि कौन सा टेस्ट किस मसल के लिए होता है, because we are preparing for a competitive examination, that too just 20 days after. Okay, so the lift off test is for the subscapularis muscle, whereas the Kennedy impingement test, yeah, also called as the Hawkins Kennedy impingement test, okay, it is done for the supraspinatus tendon. Okay, supraspinatus tendon, Kennedy impingement test, whereas speed test जो होता है, speed test is done for checking the bicipital grooves के अंदर bicipital tendon. This is your speed test. Okay, so painful arc test mid abduction में after 40 and between 90 degrees, this is the painful arc syndrome seen in case of subacromial bursitis or supraspinatus syndrome, or also called as the painful arc syndrome. Okay, internal rotation lag test जो होता है, okay, it is you flexion of 90 degrees करते हैं. External rotation lag test, drop arm test and the external rotation resistance test, all these tests जो होते हैं, just remember the name, and all these tests are used for the rotator cuff इंजरी. ओके, रोटेटर कफ मसल्स को टेस्ट करने के लिए, रोटेटर कफ इंजरी जब सस्पेक्टेड होती है, यू परफॉर्म ऑल दीज टेस्ट. जस्ट रिमेंबर द नेम. ओके, नाउ नेक्स्ट क्वेश्चन, वेरी इजी क्वेश्चन इज, a patient developed breathlessness and chest pain on second post-operative day after a total hip replacement. Echocardiography shows right ventricular dilatation and tricuspid regurgitation. Which is the most likely diagnosis? Here are your 30 seconds. Okay, very easy. Total hip replacement, major surgery के 1 or 2 days बाद the symptoms are all towards the pulmonary embolism. Okay, all towards the pulmonary embolism. So to prevent the pulmonary embolism, we do certain things. Okay, in the post-op period, we give a tablet aspirin or low molecular weight heparin, and we go for the limb elevation, okay, of the patient, and we prefer early mobilization. All this will decrease the chances of the pulmonary embolism in the post-op period, whereas in the intra-op period, we um, ream the canal of the major bones like the femur with proper care. We don't shift the patient बहुत ज़्यादा, or we don't abduct or adduct the thigh during the operation frequently, because arthroplasty के बाद these are the common side effects, the DVT and the pulmonary embolism. Okay, now next question is a very good question. Progression to congenital scoliosis is least likely in which of the following vertebral anomalies? Okay, so here are your 30 seconds for this question. Okay, so the answer for this question will be A, that is your block vertebra. Okay, so understand it like this: in case of scoliosis, progression, in case of any type of scoliosis, structural scoliosis, the progression of the deformity of the scoliosis is proportionate, or it depends on the skeletal growth. Okay, so if skeletal growth is stopped, then your progression is also stopped. Okay, so in sub options में से block vertebrae is that kind of vertebrae where there is fusion of both the parts of the spinal vertebral column, so there is no growth in the vertebra, so this is called as the block vertebra. So that's why progression is least likely in case of block vertebra, because growth is suppressed, whereas in segmented hemivertebra or the wedge vertebra or the unilateral unsegmented bar, the growth of the vertebral column or the skeletal will be there, so there will be progression, whereas progression will be halted because growth is halted in case of block vertebra. Okay, very important, remember this. Now scoliosis is the S or C-shaped sideways tilt of the vertebral column, whereas forward bending is your kyphosis. Okay, अब scoliosis are of two types. First is your postural or non-structural scoliosis, जो compensatory scoliosis भी हो सकता है due to any pelvic injuries etc. Okay, this is the most common one, the postural one. And the second is your structural scoliosis, and overall most common one is the structural scoliosis. इसमें भी the idiopathic is more commoner than compared with the congenital one. Okay, so in idiopathic, the scoliotic deformity will not be present from the birth, and most common age of presentation is a young adults wali age group. Okay, whereas in congenital it will be from the birth and even can be diagnosed in the intrauterine life. Okay, so this is your congenital scoliosis. So in case of congenital scoliosis, you have deformities in the vertebral column. Okay, so there are different types of deformities that you should know, and these are majorly the three types of deformities. Okay, फर्स्ट इज योर हेमी वर्टिब्री, नाम से ही पता चल रहा है ओनली one half of the vertebra will grow. This is your hemi vertebrae. Block vertebrae, both half of the vertebra will get fused with each other, so there will be fusion of the two vertebral bodies called as the block vertebrae. And the third one is your unsegmented bar, जिसके अंदर what you will have, there is fusion of the one side of one half of the vertebrae. Okay, so thereby preventing the growth on that side. Okay, तो उस साइड में ग्रोथ नहीं होगी, बट द अदर साइड विल ग्रो, सो द curvature will grow at the rapid phase. So fastest progression of curvature is seen in case of unsegmented bar. Okay, so in next images you will correlate them very easily. So here you can see both halves are there. Okay, both halves are there, but in one half growth is reduced, so this is not your hemi vertebrae, this is your wedge vertebrae. Okay, unilateral failure of formation, that is partial, but here you can see one half का तो कोई formation है ही नहीं, there is only single half, so complete unilateral failure of formation, this is your hemi vertebrae. Okay, now in case of segmentation defects, one half is fused completely, this is called your unsegmented bar or the congenital bar, and both halves are fused, so this is called your block vertebrae. The growth will be stopped and the progression will be halted, so this is your block vertebrae. Okay, and most common presentation in case of scoliosis में इन चारों में से most common spine deformity is your mixed pattern, remember. Okay, mixed pattern is the most common one where you have one or more types of vertebrae. So here it is a type of mixed vertebrae where you have the block vertebrae with the hemi vertebrae. Okay, so there are two types of failures. First is your failure of formation where you have the wedge and the hemi vertebrae, wedge vertebrae and the hemi vertebrae, and failure of segmentation. If it is both the halves, you have the block vertebrae, and single half, then you have the unsegmented bar, and this is your mixed type where you are having unsegmented bar with hemi vertebrae. Okay, so the symptoms of scoliosis are spinal curvature, and in case the पुअरेस्ट प्रोग्नोसिस वाला या फिर प्रोग्नोसिस, द पुअरेस्ट प्रोग्नोसिस वन इज योर scoliosis in the thoracic region, and here you will have the chest deformity called as the rib hump. Okay, fatigue, gait change, disruption of the digestive and the cardiovascular system, headache, back pain, impaired posture, all these are symptoms of the scoliosis. Okay, now scoliosis में एक तो अपन ने अभी देखा block vertebrae, दूसरा we have already seen that progression of the curvature of scoliosis is proportional to the growth, and to see the growth we use the iliac apophysis, and there is this gray or black line, and जितनी लंबी this line is उतना लंबा there are a period of growth left. Okay, so one means this is called as research sign used for the growth. Okay, so this is called as your research sign. So research sign 0 means growth has halted, progression नहीं होगा. 1 small progression, a little progression, and in case of 4 or 5 this black line जो होगा it will be extended बहुत ज़्यादा, and till the 4th this will be extended बहुत ज़्यादा, so this will point towards the progression. Okay, and very important is your Cobb's angle. Cobb's angle was in NEET PG 2022. जो साल जिस साल I had given the NEET PG, there was a straightforward question of Cobb's angle. So Cobb's angle is the angle between the first and the last vertebrae of the curvature, the primary curvature. उसकी फर्स्ट एंड द लास्ट वर्टिब्री के बीच में जो एंगल बनता है, दिस इज योर कॉब्स एंगल, एंड डिफरेंट बुक्स हैज गिवन डिफरेंट, बट मेजॉरिटी thing, and the answer for this will be, if the angle is less than 30 degrees, then you can go for the conservative management of the scoliosis. Okay, so जो first and the last vertebrae of the primary curve होती है, these are called as the end vertebrae. So Cobb's angle is between the end vertebrae, and the neutral vertebrae are the starting vertebrae of the non-diseased part or the minor curvature. Okay, so next question जो आएगा, I guess this will be on the end vertebrae or the neutral vertebrae related to the Cobb's angle. Okay, so remember this is very important, the Cobb's angle for the scoliosis. Okay, so this was all about today's session. I guess you liked the session. We have covered many important things and many things that you are not studied anywhere else. They were the first time you have studied in the paper, and focus was only my INICET and FMG based. Okay, so please do lots and lots of question practice. Okay, in NEET PG 2021 we had 100% strike rate for the orthopedics, and all questions were covered in my lectures, be it in the special or the YouTube, the grand marathon session, the MCQs, image based pen test, etc., like we have discussed today also. So you can trust us, you can trust your Unacademy for preparation of any competitive examination. And thanks for watching my lecture. If you like the lecture, please like, share and subscribe and comment, and please subscribe on the Unacademy platform, and while subscribing you can use my code, that is Anshul P10, to get extra 10% off. Okay, so